It's just a huge honor for me today to be podcast interviewing Dr. Robert Kerstein, who received his D.M.D. degree in 1983 and his prosthodontics degree in 85, both from Tufts University School of Dental Medicine. From 85 to 98, he maintained an active appointment at Tufts as a clinical professor, teaching fixed and removable prosthodontics in the Department of Restorative Dentistry. In 84, he began the original T-scan eye technology. He began studying the original T-scan eye technology and has since that time also studied the T-scan 2, T-scan 3, T-scan 8, T-scan 9, and now the T-scan 10 technology. Dr. Kerstein has conducted original research regarding the role that occlusion and lengthy disclusion time plays in the etiology of chronic myofascial pain dysfunction syndrome. His now 35 years of research with all versions of the T-scan digital occlusal analysis system has led to him becoming a leading author and researcher in the field of computerized occlusal analysis. Dr. Kerstein has been published in the Journal of Prosthetic Dentistry, the Journal of Craniomandibular and Sleep Practice, Quintessence International, Practical Periodontics and Aesthetic Dentistry, the Journal of Computerized Dentistry, the Compendium of Continuing Education, the Journal of Implant Advanced Clinical Dentistry and Cosmetic Dentistry, the Journal of Oral and Maxillofacial Implants, and Advanced Dental Technologies and Techniques. Additionally, Dr. Kerstein has published 5 volumes of research specifically about the T-scan computerized occlusal analysis technology. For many years now, he has lectured both nationally and internationally about prosthodontics, implant pros, digital occlusal analysis, and treating muscular temporomandibular dysfunction and disclusion time reduction therapy. His book is a hit on Dentaltown. In fact, this is what's really amazing. If you go to Dentaltown and you just type in his name, you pull up 24 different threads talking about him and are quoting him. And these are not amateur league quotes. These are the most amazing minds on Dentaltown. I mean, dentistry, you know, it's caries, perio, and occlusal. And I assure you young kids out there today that you are listening to the heavyweight champion of the world in this occlusion, and now which is going to computerize occlusal analysis. And I was very excited to get you on the phone because all the rumors coming out of Align Technology, which owns Invisalign and the iTero scan, it turns out that the iTero, all these scans, their algorithms are starting to understand occlusion. So, you know, you can take an x-ray and say, oh, here's some cavities. For perio, you can say, here's some bone loss. And now we're seeing AI is going to start diagnosing and treatment planning and giving us measurements for occlusion. And does that sound cool to you, or does that sound like a scary movie?
Well, first, I need to say that any of the opinions that I expressed today are mine and not necessarily that of TechScan. So,
hey, you're on Dentistry Uncensored. This is like HBO. You can say whatever you want.
Well, it's important that I clarify that, as I am a consultant for the company, but I do not receive any compensation for sales.
Nor do I.
Well, that's a good thing, I guess.
Yeah.
To answer your question, it's a great thing that dentistry is moving towards digital occlusion, but it's important that the listeners understand that scanning technology actually is only really using geometric approximation of contact size, and it helps design occlusal contacts in restorations, but it actually has no actionable force or timing data in it. And so it still doesn't preclude the need for computerized occlusal analysis of the restorations after they're installed. So there's a kind of a misrepresentation in the scanning world that there's actually forces in there, and there's no forces in there. It's all the geometric approximation of spatial orientation.
So you're not a big fan of it then, of the early stuff. You're talking about the early stuff, the AI stuff coming out of these intraoral scanners into computers, that it's all...
No, I'm a fan of it because it means that there's digital occlusion being fostered and adopted. But it's important that people understand that it's not real forces. it's not measured, taken from the patient as you would be with a T-scan sensor, which is designed to measure forces and timing and give actionable data to a clinician to be able to use. And so the scanning companies, it's great that they're going digital and trying to represent occlusion, but it's not the same as what the T-scan does.
Okay, we'll explain the difference between those two things, between the T-scan and what you're saying that these intraoral scan data are showing.
Well, the T-scan, the patient occludes into a sensor which is designed to measure relative force and time sequences and give out pressure mapping and actual relative force information to the clinician. And so it maps the pressure of the arch as the patient occludes or discludes every tooth in the order and sequence that teeth hit. And it provides you with data that can be used to make targeted occlusal adjustments, make a complete occlusal analysis in a way that no other technology is capable of doing that. And it's because the data is taken directly from the patient's teeth as they interface, as they mill against each other, as they strike each other. And that the difference is that scanning is pictures of the occlusal surfaces that are then put together and approximated, kind of like hand articulating stone models. There's no force in there that can be taken from pictures. It's just surface anatomy. And then they're fitted together, which is very nice and it's very positive in that it allows people to digitally articulate and digitally move casts around. But there isn't force information inside there, even though it's created geometrically. It's not real forces.
So you and I, we're old, and when people send in an email, howard@dentaltown.com, a quarter of them are still in dental school, and the rest are all under 30. And so we're probably the two oldest guys who are going to listen to this show today. Let's go all the way back to dental care, dental kindergarten school. They're going to learn dentistry, caries, perio, occlusion. Starting with occlusion, these kids, about a quarter of them have a family member that's still a dentist. Their mom, their dad, their uncle. What do you think? We've been practicing 30 plus years. What do you think their dad's letter grade in for the average dentist in America? What would you give them for a letter grade for treating caries versus perio versus occlusion at current 2020 standing?
Well, certainly the education that our generation got about occlusion, about caries and periodontal disease was the center of our education. And occlusion, really, I didn't learn occlusion in dental school other than basic, try to make it fit in and not cause too many, untoward reactions. I only really began to understand occlusion in postgraduate. So people in our generation would have left school and then gone on and taken continuums to learn occlusion. And unfortunately, most of those continuums didn't teach digital occlusion. So our generation practitioners are a little bit behind in that digital occlusion is a major advance for the patients as well as for their practice. It's so helpful to many aspects of dental care that are trouble in the typical dental practice. And so, the basic occlusal concepts are there from what we learned, about time and distribution of force should be balanced and time, everything should hit at the same time. But those things are concepts that can only be actually achieved when you measure the teeth. So the younger generation, if they're exposed to digital occlusion, will have a leg up on our peers.
So, what letter grade would you give the average American? So there's 211,000 Americans who are living with an active license to practice dentistry. There's 2 million around the world. Keeping it just in the United States, a better sample size for our personal framework. What letter grade would you give those 211,000 dentists, as we know dentistry today in 2020, for caries, perio versus occlusion?
Well, caries, I'd have to give an A. And periodontal disease, I'd have to give an A. And occlusion, I'd have to give like a B or a B minus. And the reason I say that is many dentists do try to learn occlusion from the continuums. They make a serious effort to go away for a week and learn, from the experts. And, that's a real statement that they're really trying. But the concepts of occlusion are not advanced to where we are in digital occlusion. So no matter what's studied is generally somewhat behind what we know from actually measuring the occlusion, which only really began in the 1980s with the T-scan.
Okay, so before I get into this, it's kind of like I don't want to start telling this young kid in dental school how to drive from Phoenix to LA and how to get on I-10 and all that without first trying to explain to him why he should want to go to LA. So what do you? So if you get an A in caries and a B and an A in perio, but let's just say you get a C in occlusion or a D, why does that kid want to learn occlusion? Why does he want to go to LA? Why does he want to learn this? If he doesn't learn occlusion, what's going to bite him?
Almost every procedure that he does. Occlusion is the most difficult aspect of dental care to manage. It's why there are so many complications. For example, the most common thing that I came across as someone who sought out patients who sought me out for help with their occlusions was the most common story was I had 3 fillings changed and my bite changed, and that was 4 years ago, and now I have TMJ and no one's been able to help me. Or I had 3 crowns put in, or I had a tooth extracted and my bite changed and I got pain and people started adjusting my bite and now my bite doesn't fit. And so occlusion is the success or failure of most of the things that we do. And of course you can have aesthetic failures and you can have restorative failure, but restorative failure that isn't decay related, that's fracture, breakage, dislodgement, implants unscrewing, parts unscrewing, that's all occlusion. And so the most central thing to long-term success is for dentists to learn, high quality principles of occlusion. And the advantage of the T-scan is that it measures the occlusion, and no other technology can do that. There's no articulating paper doesn't measure anything. It just marks teeth. And that's a big problem that dentistry doesn't really grasp. It's necessary for marking teeth, but it doesn't show you force or time or quality of the occlusion or balance or distribution. And so these are things that a young dentist would really benefit from because they'd be starting out using measurement, and learning occlusion will only help them to succeed better in practice.
So then let's go to the birth. I don't know how many children you have, but I think the first one was the T-scan 1. Did you have any children before 1984 with the T-scan?
No, my son was born in 1989. So.
Well, don't tell me 1989. What T-scan was he? Was he born T-scan 2?
He was born after.
So you had a T-scan before you had a child. That's pretty. That's pretty rockin' hot cool to say. I had a T-scan before I had a child, but so the that was in 1984. You're talking to a bunch of people who weren't even born in 1984. It's 2020. They probably weren't even born in 94. If you were born anyway, but so go back to 1984. Tell these kids what it was like and what was this new T-scan 1 technology, and why did it interest you?
Well, it was the first version of a system that actually took forces from the patient. That was what interested me. We were taught, I'm sure you were taught the same thing, that you could see force in articulating paper, or you wanted all the forces to be equal, or you wanted distribution of forces, but you couldn't detect that in any real quantifiable way. And the T-scan 1 was the first attempt by anybody to actually measure occlusal forces in a distribution of the arch. There were attempts to measure absolute forces on single teeth. There were a number of strain gauge studies done and things like that, but they weren't applicable clinically. The T-scan was the first dental technology, actually. It was built right around the time that CEREC 1 was built. And those two were the earliest technologies, and they actually incorporated computer assessments. So the T-scan 1 sensor was the first device that actually drew forces out of the patient. And that's what interested me, that I could actually determine, were the teeth really balanced? Were the forces distributed correctly? Were they timed simultaneous? Did someone disclude immediately as the concept presented to us? And interestingly enough, none of that was really true. people's teeth didn't hit at the same time, and people's teeth didn't disclude instantaneously, and there wasn't even distribution of force when you had lots of paper marks on all the teeth. So there was a lot of information there that was brand new and eye-opening, and that's why it interested me.
And you are in Boston, Massachusetts. I want to fill in this story. So the reason, it's no small surprise that a guy in Boston would pick up on it first is because it started off with MIT first, and it was in 1981. They discovered a new tactile sensor, and then that was a component that had to be invented before you even sort of started a tech scan, right?
Yes, TechScan, the company, was formed originally with a number of prosthodontists from Tufts who were my teachers and MIT engineers. And they created this time and force measurement system with this tactile sensor that you just referred to, Howard. And they made 16 prototypes that were distributed to, I think, only prosthodontic programs, the most prominent prosthodontic programs in the United States. And I was in one. I was at Tufts, where my faculty were part of the development team. So I had access to it pretty much from the time I entered postgraduate. And no one understood it. No one knew what it really meant. No one understood how to take the data and turn it into a better denture, or to assess quality of the occlusion. And that's what I began to study with it. And over the years, we really began to understand what you could do with this digital data that measured force and time and pressure.
And who was the original founder of the TechScan company?
It was a prosthodontist named Dr. William Manis, and an engineer from from MIT, Rob Podoloff, and a couple of his associates.
So the founder of TEKSCAN who was the first guy you said?
Dr. William Manis, and a number of other dentists who
M-A-N-N-I-S?
M-A-N-E-S-S.
M-A-N-E-S-S,
yes.
M-A-N-E-S-S. So William Manis was the founder?
Yes, along with a number of other faculty personnel at Tufts who invested with him, and they were combined with engineers from MIT.
And how far is MIT from Boston? I mean,
It's
from Tufts?
You could walk there in 20 minutes or take a taxi in 5.
And so so that journey's been on a long way. I mean, I say when T-scan 2, 3, 8, 9. I'm kind of confused about these numbers because it goes 1, 2, 3. No, there's no 4, 5, 6. Then we got an 8, 9, and 10. Is this like a Star Wars thing where you launch movies 4, 5, 6, and then later you'll launch 1, 2, and 3?
Well,
so
it's a series of changes to hardware and software configurations. And as Windows developed, there was changes to the T-Scan 1. The T-Scan 1 was a standalone entity like an oscilloscope. And it had a recording handle that plugged in, and it had this original sensor that you alluded to. And it measured 3 seconds of occlusal contact timing and force data, and played a movie of the bite. So it was a very dynamic look at the bite, which was fascinating, actually, as a young person. And we didn't really have computers back then. We didn't have laptops, and Tufts at the time didn't have computerized records. There weren't computerized x-rays. As I said, the T-Scan 1 and the CEREC 1 were built around the same time. And through the years, as Windows technology and chip technology evolved, the T-Scan evolved. And the company, TechScan, also applied the sensor in many different ways. You can walk on the sensor, you can drive on the sensor, you can sit on the sensor, you can bite on the sensor, you can put it on the outside of airplanes and measure wind shear. You can put it on baseball bats if you want, golf clubs, horseshoes. I mean, there's millions of applications, engine gasket seals. And so they began to develop a corporation that expanded the use of the sensor. And what they learned in these industrial applications, they put back into the different versions of the T-Scan. And T-Scan 2 was a Windows-based platform. And T-Scan 3 was better hardware, and better Windows had evolved from Windows 95 to Windows Professional. And I mean, it all evolved together. And T-Scan 10 is the current day version, which has capitalized on all those iterations and has a really amazing new handle. The Novus handle and the Novus sensor, incredibly ergonomic, and the handle does all kinds of things. It can play the data for you. It records the data for you. It controls the amount of pressure, not the pressure, but it controls the amount of load, the electricity in the sensor. So you can customize that to fit a patient's bite strength. There's all kinds of improvements, but the essence of the different versions is they evolved along with computer technology, and also to match doctor desires. Various software features were put into the different versions that people were requesting. And things like in the current version, T-Scan 10, there's implant warnings. If an implant is overloaded, you get a warning. It tells you automatically, there's too much force on that implant. And so these are the kinds of things that have been added as time has gone on.
And how much is it, and how do they get trained on it?
Well, the system costs about $10,000 US, and training is provided by TechScan. They've constantly evolved the software to simplify the training process and shorten the learning curve. But any technology that you implement in your practice requires time and practice to learn. And in the T-Scan, the most crucial thing to learn is how to record digital data from the patient. And fortunately, the company has excellent trainers that teach doctors who get involved how to record and understand the data. And usually they can get started pretty much from the company training. And then there are many online resources, and people who really want sophisticated training can actually bring me to their office, and I can mentor them chairside with patients and teach them how to use it one-on-one.
So how much does that cost?
It depends on the date, the number of patients they want to see, but generally for that personalized training, between $4,000 and $5,000 for a visit.
I wish you would do a CE course on Dental Town.
Well, we can certainly talk about that. I'm happy to do that.
Yeah,
that would be an honor.
I would love that. You have some huge fans. Again, go to Dental Town and just put in just your last name, Kerstein. And my God, it flies over. Two of your biggest fans are Mark Piper and Nick Yanios.
Nick Yanios.
How do you say it?
Nick Yanios.
Yanios. Is that Greek or Greek?
It's Greek.
It's Greek. Okay, I was wondering that. So are these your buddies, or do you know them well, or?
Yes. Well, I've known them for a long time. Mark Piper is a very world-renowned oral surgeon who treats a lot of temporomandibular disorder patients and has, in his own way, evolved. He and I have kind of had parallel careers. His in imaging, CT and MRI, which he's evolved for dentistry, which he began also in the 80s when those technologies were first introduced, and he's really changed how people analyze internal joint arrangements and skull-based problems and condylar deformation and diseases of the joint. And at the same time, I was evolving the T-Scan technology. And so we both started around the 80s. Dr. Yanios is a very prolific computerized-based dentist who practices with CEREC and chairside restorative work. He's been a leader in that area of dentistry, and he's participated in both of my research handbooks about the T-Scan, and we've done studies together. He actually discovered that using the T-Scan can greatly improve cold sensitivity in teeth without changing fillings, without using medicaments and desensitizers, that it's really a bite-related problem from pulpal hyperemia that comes from excessive bite pressure and too much lateral stress. And so he's been a prolific advocate of measuring the occlusion and measuring the joints. And he's sort of helped both Dr. Piper and myself educate dentists throughout the world.
And what about William Mannis?
Well, Dr. Mannis was my teacher in prosthodontics, and it's interesting. He he tried to interest dentistry in the T-Scan 1. And at the time, in the mid-'80s, he lectured all over the country about the benefits of measuring the occlusion. But the T-Scan was a little early for computerization in that dentists weren't really acclimated to computers. As I said, we didn't have laptops or desktops or computers. The school, Tufts had no computerized records. Everything was still on paper. And so it kind of preceded the computer era. And although I wrote a lot of articles about it and began to study it, by the time he decided to retire from practicing prosthodontics, the T-Scan was still in its infancy.
Huh. So how is TechScan doing today?
Well, it's a worldwide company that has many engineering applications. As I said, the same sensor can be shaped in many different ways. So there's podiatric applications, there's industrial applications, there's the biggest area that I'm aware of is the automobile industry, engine seals and gaskets, windshield wipers, how they sit on a windshield chair, automobile ergonomics, how you sit in your chair when it speeds up your car seat, how it's designed. They also have wheelchair applications. They have sports applications. It's a ever expanding number of applications because it's one of the few sensors, the T-Scan sensor and its siblings, all measure time and force. And so you have dynamic information. So an example would be if you wanted to measure the gait on a racehorse, you put these sensors on the horseshoes and the horse runs around the track and you get gait analysis and timing analysis. And, I'm not a horse person, but I mean, that's just one application. The same applies to people. Posture, there's posture programs, there's balance programs, there's podiatric programs where you can measure a human gait, human analysis, and how much pressure is on a foot. You've actually seen, Howard, I believe, if you've ever seen a commercial for the Dr. Scholl's kiosk, where they show you someone standing in front of this machine and above their head is a sort of a red, orange, blue, green foot that that's a T-Scan color map shaped in a foot. And when you step on the kiosk, it tells you what orthotic fits your pressure map. So those are just, the many applications the company has been able to use the sensor for. But the original sensor, as you pointed out, was the T-Scan 1 sensor. And that goes back a long way.
And who in their company, who at T-Scan's in charge of just dental and not auto and all the other places? Is that you?
The dental division is headed up, the medical and dental division is headed up by a man named Dave Nelson. And the product manager is Alyssa Rubino.
So since automobiles is so much bigger than dentistry, do you think TechScan will be moving? Do you think dentistry will become smaller and smaller part of it?
Well, I think the dental and medical division stands on its own, meaning that it's not that it's not separate from the company, but there's applications in medicine and dentistry that are important to the company to develop and evolve. And TechScan has put a tremendous amount of iteration and hard work into making the T-Scan a very valuable product with, for the dental practitioner and for the patients who are receiving the care. It's a real game changer. So I don't see them minimizing the medical and dental division, but I'm not privy to that information. I mean, I couldn't really answer that question for you. But in my experience, I can tell you that the T-Scan has been evolved to meet the needs of the dental practitioner many, many times.
So when you and I got out of school, occlusion was bite, tap, 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 and the big occlusal questions were, can I just do this with a metal quadrant tray, or do I have to take a full arch and mount it on an articulator? And now it's digital occlusion. And
yes.
Now I'm a big fan of you, and you have a big book on Amazon with all 5-star ratings. You don't even have a single 4-star rating. Handbook of Research on Computerized Occlusal Analysis Technology Applications in Dental Medicine, 2 volumes. Tell us about that book. And I've always said writing a book's like having a child. It takes more than 9 months to make. Tell my homies what they would learn if they got that book. And is it a book they could do on Audible? Because, millennials like to read books in their earphones while they're in yoga class or I assume eating kale or something like that. Or is this a book where you need to buy the book to see the pictures and the diagrams?
Well, exactly. Well, yes, you need to be able to see the diagrams and the images to be able to understand the context of what's being described. But there are 2 versions of the handbook. The 2-volume handbook came out in 2015, and that we recently updated to a 3-volume handbook in 2019, and that's the latest version. And the handbook contains every known application of the T-scan in orthodontics, T-scan in prosthodontics, T-scan in implant dentistry, T-scan in periodontal disease, T-scan in patient education, T-scan in occlusal diagnosis, T-scan in TMD. So T-scan in cold sensitive teeth. It's a vast T-scan in digital workflow. It's a vast resource for anyone who wants to learn how to use computerized occlusal analysis in any discipline of dental medicine. And it's all backed by research. We've been studying these things for a long time. There's 300 T-scan research papers in the literature, at least. I can't tell you the exact number. And numerous clinical reports and detailed explanations of how to use the T-scan. Now, one of the most interesting chapters is T-scan in posture and T-scan in balance. And so the handbooks are really a complete treatise on how to use the T-scan in the variety of disciplines that we all face on a daily basis.
And so we're starting to go into digital dentures. Do you see digital occlusion and digital dentures merging?
Of course, because digital dentures, again, are like scanning. You get pictures of your denture, you make it, in a milling machine, or you make it in an injection molding machine. It still has to be adjusted occlusally. Nothing about the scanning and milling process negates the delivery of the occlusion at the time of insertion. And although the scanning companies may want people to believe that they have forces in there they can use that are actionable, that's not the case at all. You cannot make forces out of pictures. You need to draw that information out of the patient. And that's where the T-scan technology is unique. It's the only available technology that allows you to actively measure intraoral pressure interface forces of the teeth gnashing against each other, milling against each other, banging into each other. And so a digital denture would be made digitally, processed however it is, come out to go into the patient's mouth. And then at the insertion stage, you would use a T-scan to control the forces on the delivery.
And my God, it's come so far. I mean, I remember when I was in school from 83 to 87, the big new thing in TMJ was condylectomy and replacing with artificial condyles.
Yes.
And then remember when the boys at LSU had a special coating on that, and then that broke down and fell apart.
Yeah.
Do you remember that one?
Yes.
Yeah,
yes.
that was a big one. And then and in fact, Mark Piper used to be St. Pete's maxillofacial surgeon in Tampa. So in your journey, I don't know if there's a history of TMJ surgery, but how does Mark Piper, being an MD, DDS, oral surgeon, used to be Pete's TMJ surgeon, how does the surgery component look today? Are you seeing less surgery, or is the surgical component of TMJ going up? Is it flat, or is it contracting?
Well, to be honest with you, I couldn't answer that because I'm not a surgeon, and the applications of the T-scan fall into treating the applications in TMD fall into treating the occlusion where the joints are stable and intact and mildly, let's say a disc is mildly displaced, partially displaced. But once you get into the surgery, you're dealing with, major structural skull-based problems or major condylar problems, disc completely displaced. So I think there's still a fair prevalence of that, and there's still a fair prevalence of occlusally caused TMD. But percentage-wise, it's pretty well known that most patients who have TMD symptoms are really about 80% of them are mostly myogynous muscular problems. That's where the occlusion is so key, and the T-scan really helps with that. That's one of the greatest advances in use of the T-scan, is that it greatly cuts down on the number of splints. We have many studies which show how the proper use of the T-scan lessens symptoms, cuts down on clenching and grinding, reduces headaches, reduces facial pain, improves chewing. These are all things that we've been researching. Whereas the skull base breakdown and condylar breakdown, you would determine that in advance, and if that's the case, that would supersede any occlusal treatment to deal with those disease states. And then ultimately, when whatever that led you to, if that meant opening the bite and creating space for the condyle to regrow, and then later putting the teeth back together again, that's where the T-scan would come into it. Wherever the teeth are part of the treatment, that's where the T-scan would come in. But as I said, I can't honestly tell you whether surgery's gone up or gone down. You need a surgeon to tell you that.
Well, I mean, we both know. I mean, we both we hear less and less of our colleagues talking about it. I mean, it's you don't. I remember in '87 it was routine when the pano came out. If the pano, the condyle looked funny, you'd send it to oral surgeon to look at the condyle, and
Yes.
and sometimes they'd recommend that it be chopped off. And I mean, I haven't even heard of that in 2 decades.
Well, maybe condylectomy may be on a downswing, but arthrocentesis and open joint surgery may be equally as prevalent, barring condylectomy. But again, I wouldn't be able to answer that. Imaging has really improved our understanding of how to determine that. And so, although a panoramic X-ray can show you some things, an MRI far more descriptive of the true structural breakdown of the joint space, and CBCT also far more instructive of those things, because you can manipulate the views and you can turn the anatomy around. You can look at the condyle from 360 degrees. You can cut the patient's head in half and slice right through the different parts of their joint and see the structures. And so it's possible that because of imaging, there may be less of a need for surgery because more can be known diagnostically. But again, I'm not one who can tell you definitively.
So do you think a T-scan is a standard technology for your basic family and restorative general dentist who does fillings and crowns?
It should become that. And it should become that because the nature of articulating paper is so nondescript, and dentistry has relied on principles of how it's used that are not scientifically valid. And I think that's a huge problem for the patients. And the patients suffer complications related to dentists using articulating paper in a very unsupported scientific way, whereas the T-scan completely or nearly completely eliminates that subjectivity that articulating paper offers the clinician. So yes, I would say the family dentist would benefit from the T-scan just the way high-level implantologist would benefit from the T-scan, because the occlusion of a single crown or 28 crowns is still potentially a problem. As I said, many of my patients who sought me out came in where they only had 1, 2, 3 fillings done, and they lost control of their bite, and they had then developed TMJ symptoms that no one was able to resolve for many years. So a simple dental procedure, which doesn't seem like it would, throw off someone's occlusion, certainly can do that. And at the core of that is the choosing marks subjectively based on looking at ink spots. It's not very scientific, and research is very clear on the ineffectiveness of that methodology.
So you think you're hoping that we start moving occlusion from analog to digital? You think tech scan would be a much better thing for that? Do you think the CBCT is as mandatory as a tech scan to understand this occlusion?
Well, I think the CBCT is mandatory to look at the joint anatomy and skull structures and anatomy, but not the micro-occlusion. CT can't help you with the micro-occlusion, and MRI can't help you with the micro-occlusion. It can only show you the orientation of structures and their level of damage. bone, calcium changes, abrasion, wear, structural breakdown, but not treatment. Treatment of the occlusion is really at the tooth level. And the interface of the teeth meeting and mating and milling and gnashing against each other, that's what the dentist on a day-to-day basis has to manage. And so, yes, the T-scan is at the core of managing all of those things. But a CT is really a diagnostic tool, a great diagnostic tool, and very helpful, as is MRI, but not in terms of actually treating the occlusion.
So it started off with a force sensor from MIT, then it went to a matrix pressure sensor. Now it's a pressure sensitive film, position sensors. It seems like this, the MIT technology of this is kind of in a Cambrian explosion. It seems like it's really coming out with a lot of iterations, going in a lot of different directions from dentistry to cars. Does it seem like that way to you?
Well, that's what happened. And the sensor was evolved as things about it required improvement. So the current day sensor is not the same sensor as the T-Scan 1 sensor, obviously. And it's has a very long shelf life. T-Scan 1 sensors didn't have a long shelf life. They were epoxy matrices. These are new sensors are mylar matrix with conductive ink and a lot of sophistication. And the TechScan researches and analyzes their sensors and on a regular basis for accuracy, repeatability, durability. And so the applications in other industries have stemmed out of the original T-Scan 1 sensor, but the sensors in all of the fields have evolved in order to meet today's needs.
And a term that I get a lot of questions on is biometric. You say treating occlusal problems with the biometric method using T-scan and electromyography. Go slow with that because the ones in dental school have not heard of probably electromyography, and biometrics seems to throw them off too. So will you explain that fundamentally?
Sure. Biometrics is simply a term that connotes using measurement. And bio means measuring biology. So we can measure, not only with the T-scan, we can measure the occlusal forces and timing, but there are some amazing biometric technologies that measure muscle physiology, that measure chewing function, that measure jaw motion, and joint damage, if there is joint damage. And so combining them all can greatly aid in the diagnosis of a patient's occlusal status, their muscle physiology. If they're a chronic pain patient, do they have dysfunctional muscle physiology? Do they have normal muscle physiology? If they have joint problems, are they displaced discs? Are they bone-to-bone contact? Do they affect their chewing motion? Do they affect their chewing strength? There are all kinds of things that have been studied using these biometric technologies that pair with the T-scan. So you can work with 3 technologies on one patient, for example, all paired together to get a full profile of their true function with measured data. And for example, chewing can be measured, the speed of chewing, the arc of chewing, the dysfunction of chewing. The teeth can be measured for how much pressure there is on some of the teeth, how much is too much in some area and not enough in other areas. The muscle physiology can be measured as to whether there's extreme contraction strength, whether there's weak muscle strength, whether there's hyperactivity present at rest. So there's so many things we can measure that we have the capability of truly diagnosing a myriad of occlusal related issues. And so using these biometric technologies in tandem is really the secret to that.
And the difficulties dentists face in practice using subjective occlusal indicators like articulating paper, which studies show dentists struggle to interpret properly and leads to many occlusal complications. I mean, the way I see this is, there seems to be a lot of voodoo in occlusion. Like dentists will always say, leave the temporary high, and when you see me at the crown, take it out of occlusion. I mean, there's just all kinds of weird stuff like that. So I want to ask you, and I know this is ask you to, you don't want to make it too simple, but Let's go through. I'm trying to think like it was when we got out of school in the 80s, right? So their first question is, okay, if I'm just doing a one-tooth crown, this is how they think. And the reason we leave anonymous on Dental Town, and the reason it's been growing 1,000 members a month since we've launched it, is because you can be anonymous. We know who you are, so you have to register. We have to know who you are. But if you want to go out there and tell them that you're Dr. Biometric, knock yourself out. Because Rella Christensen, Gordon's wife, was the one who convinced me when I was dealing with transparency. She said, Howard, there has to be a place to ask a stupid question. She goes, every time you lecture, you say, okay, is there any questions? No. Okay, well, let's all take a 15-minute break. And what does everybody do? Run up to you and ask you that little personal question, because theirs is unique, and it's as unique as everybody in the room. And what I usually do is just write them down, answer them when they come back. So this is what they think. That, well, if I'm just doing one crown, I don't need to know all that occlusion stuff. I can just do a quadrant tray. Now, if I'm going to do a bridge, well, then I should do a full arch. But then, Howie, when should it be mounted on an articulator? So that's how they think. So address that. So go to one-tooth dentistry. And you watch their career, they start off with one-tooth dentistry. And it takes 4 or 5 years before they start doing quadrant dentistry. And I don't see really anybody doing full-mouth dentistry inside of their first decade, unless maybe their dad was a dentist, or or they were really motivated. But so just start with that. Do I have to know occlusion for one-tooth dentistry?
Absolutely. Absolutely. As I said, many of my patients had 1 or 2 or 3 teeth worked on, and they went south. And it happens very frequently. Any patient that's been treated with a single crown who comes back 5 times complaining about their bite has had an occlusal change. So yes, a single tooth can.
But when they have a bite problem, I know what my homies all do. They just come back, have you bite down, wherever it hits, they take it out. So. What do you think of that methodology? Oh, well, if that still hurts, we'll just keep taking it out of occlusion until you just quit coming back.
Well,
do you agree that's a normative treatment?
I think it's what happens, but it isn't in the best interest of the patient.
Okay, but explain to them why.
Because when the tooth is taken out of occlusion, if that's the ultimate endpoint, other teeth strike worse, or let's say neurologically less well tolerated. See, the occlusion is like a piano. A subtle change in one key, and can affect many other places in the arch that you can't predict. And so a single tooth can start a cascade of many downturns, which again, I've seen many times. And other times a single tooth has no bearing. If it's taken out of occlusion, it doesn't change the patient's comfort zone. But the difficulty is you don't know who that is. You don't know who that is. And so when a tooth is taken out of occlusion, it can start a cascade of many things. And I've seen it for years and years and years. So single tooth dentistry doesn't preclude someone from needing to understand occlusion. And multiple tooth dentistry doesn't mandate that they are able to do it if they don't understand occlusion. But it's not well defined by our profession. But I would caution people to think that even a single tooth has to be handled well occlusally, or you can have neurologic changes that are untoward. And this is why patients come back for many visits sometimes after having something done that changes their bite. And the beauty of the T-scan in those situations, it really shines in those situations, because it shows you, if you took a record beforehand, and then let's say you had made a single crown and the patient had trouble adapting, you'd be able to compare when they were stable to what you provided to them and make targeted corrections to get them back to where they were. But that's not the case with non-digital occlusal indicators like wax and articulating paper and stone models. You can't see what's really going on pressure-wise, force-wise, time-wise. And so single tooth dentistry warrants a lot of knowledge about occlusion, just like any other dental procedure.
And are you familiar with Ben Sutler?
Ben Sutter?
Yeah, Ben Sutter.
Yes, he's someone who I've personally trained in his office on how to use the T-scan and treat TMJ patients with the T-scan. He's become a very prolific author and lecturer. He wrote one of the chapters in the new handbook.
Because you just have the biggest fans on Dental Scout. Like when Ben makes a post on TMJ, okay, like here's a post he just did. He posts references Kerstein 2, 3, 4, 5, 6. He quotes 8 different publications that you he quotes you 8 different times in 8 different periodicals. The effects of reduced disclusion time in the treatment of myofascial pain, journal. But anyway, it's like it's like talking to a minister quoting the Bible. I mean, you are just all my friends that are over the top in occlusion, dude. They always quote you. Have you ever thought of starting a church?
Well, we sort of have a digital occlusion following that is, people want to advocate for the need for the patients, that it's researched, well-researched treatments that they're rendering. And the benefit to the patient is dramatic. And so Ben has become very sought after because he's been using these principles, and he's found them to be very helpful. So I'm sure that's why he's citing them.
So for the kids, again, knowledge has no value if it's not transferable. So to the kids, where do you think they're going to get in trouble first with occlusion? Is it going to be one-tooth dentistry? Is it going to be their first 3-unit bridge? Or is it going to be, I know a friend that posted this case on Dental Town. His first crash into the wall was when he did a smile makeover, the front 10 teeth with veneers. And I mean,
Yes.
He even says on the deals, I mean, the veneers are on the outside, the buccal side. He didn't even see this occlusal nightmare coming. But after he did 10 units of veneers on someone, that was when he first crashed. Where do you think they're going to get into trouble first?
I think what sets anyone up for trouble is relying on the subjectivity of the non-digital occlusal indicators. So any case could be a patient could start a patient downturn. It doesn't necessarily have to be a big case. It could be a single unit. It could be 3 fillings in a quadrant. It could be, a set of veneers. I would imagine in that 10 veneer case, he might have come over the buccal on some of the premolars, and that would be a change in the occlusion in that area. And that's, again, if there was a 10 veneer case and he came over the buccal cusp of 4 of those premolars, that's a 4-unit case that just changed the occlusion for that person. So it's really the subjectivity that predisposes dentistry to these kinds of problems, not the procedure itself. It's the lack of measurement and choosing paper marks by how they look using principles that have no scientific foundation. And unfortunately, they're still being perpetuated. Those principles are: a big mark is forceful, a little mark is light force, and contacts that have holes in the middle of the ink are forceful. None of that is true scientifically. It's actually been shown that a big mark is only forceful 14% of the time. So that means if you go by that method, you would choose incorrectly 86% of the time. And just by choosing the wrong mark, you can start an occlusal cascade. And this is what I saw for years in my patients coming to seek me out in my practice. Okay,
so again, I always try to be the champion for our replacements, right? The kids in dental school. Their succinct question is, when can I go with a quadrant tray? When do I have to go full arch? And if I had to go full arch, how would I take a CR record?
Well, interesting. Those are all very good questions. There isn't a right or wrong answer. You can make a single unit in a quadrant impression and succeed very well with a patient who's not so occlusally affected, and I don't mean they start out with TMJ. I mean, you just don't know who it is that a quadrant impression might be adequate for, and then you could argue, well, if I did a full arch impression, did it change? I still had the patient come back 5 times for occlusal adjustment. So it really isn't the protocol of the making of the teeth, because we can make nice teeth with digital methods. We can make nice teeth with a beautiful technician can make gorgeous teeth. It's the protocol of the insertion. That's where the trouble comes. And so I can't tell you there's better answer that a full arch impression is guaranteed to minimize single unit crown problems over a quadrant impression. It's not true. Any restoration could be greatly accepted by the patient or greatly unaccepted by the patient, depending on the occlusion that's given to them. And if it's ground out of occlusion, possibly because other teeth are now striking poorly that were not anticipated. So without a full arch view of the occlusal pressures and timing, it's very difficult to know whether a good result has been installed or not. And so, again, that's one of the beauties of the T-scan. It gives you a full arch impression, not an impression as in stone model or digital impression, but a force impression, a timing impression of the full arch, every tooth and what it's doing pressure-wise.
My favorite thread on Dental Clit Town is what are the zombie ideas in dentistry that have been thoroughly refuted by a mountain of empirical evidence, but nonetheless refuses to die, being continually reanimated by our deeply held beliefs? What are the zombie ideas of occlusion that we know went out with the Flintstones, but there's a bunch of people that are old, and by old I mean anybody who's an hour older than me, still hangs on to and believes?
Well, there are many in occlusion that have actually been proven scientifically invalid. Probably the most important one for the young dentist is that the principles of paper marks that I just told you, that big marks are not forceful very often, and small marks are often very forceful because they're like stiletto heels. You know, if a woman steps on your foot when you're dancing with her with a 4-inch stiletto heel, it's going to kill your foot. But if she stepped on you with a sandal, flat shoe, it's not going to hurt so much. Well, that principle applies in dentistry, and we don't teach that. We teach it actually completely incorrect, that the paper marks illustrate force by their size and by their color depth. It's actually been shown in research that the bigger marks and the darker marks have less force in them because the ink survives on the tooth surface because the pressure gradients are very low. So in other words, when you have a lot of ink, you have very low forces. And when you don't have a lot of ink, it's because the ink gets squeezed out by the pressure. The ink is a physical entity. It's not a marker of force. It's just a physical entity. And when there's too much pressure, it gets squeezed out into little bits, and the carbon paper gets destroyed into little bits. So we're teaching this, in your words, outdated dinosaur, belief, zombie belief, that really gets dentists in trouble. And it's all been proven incorrect. And another one that's really a zombie.
Wait, you got to make that one under 10 words. The principles of occlusion that bite paper marks matter. Would you just say that?
That articulating paper marks measure force and show force by size and color depth is completely unfounded in research. And what's worse than that is that when dentists are tested for their ability to choose forceful contacts, by looking at paper marks, they perform very poorly.
Okay, say again. What I have, the principles of occlusion, the zombie ideas of occlusion, that articulating bite paper marks are based on force.
That articulating paper marks show force by their size and color depth.
Show force based on their
size.
Size?
Yes.
Size.
And their color depth.
And their what?
Their color depth.
Color depth. Okay. So the zombie ideas of occlusion that articulating bite paper marks show force based on their size and their color depth.
Yes.
Is that right?
Yes.
And then you would say, which is totally false, or what? How would you?
It's totally unfounded. It's been already been disproved in studies. There are studies that have been done since 2007.
What's another zombie idea of occlusion?
That TMD is not an occlusal problem. TMD, the number one cause of TMD is occlusion. And we've also proven that for many, many years with T-scan studies. But the literature is, whenever they do one of these meta-analyses that
start it again. That TMJ what?
That TMD is not caused by occlusion.
So you're saying the zombie ideas of occlusion, that TMD is not caused by occlusion.
Right. And that's totally incorrect.
So you're saying it is caused by occlusion.
Absolutely. Occlusion is the #1 perpetuator of TMD problems.
And what would you say to the guy who says, well, is it psychosomatic? I mean, this girl's grinding her teeth, but she just lost her job and going through divorce.
Yes, stress is additive, but it's not causative.
Stress is additive, not causative.
Yeah, it's additive, not causative. So her bite is causing high muscle firing, which is why she's grinding her teeth, and her job gets lost and she grinds worse. But we actually have studies that show we can stop the grinding and the clenching and the emotional aspects. We did a very interesting study in 2018. We took 80 patients who had TMJ problems who were emotionally depressed. So they filled out a depression index, a known depression study, something like the MMPI. It's called the Beck Depression Inventory. And when we did that beforehand of all 80 patients, then that classified them into mild, moderate, severe depression, borderline depression. There are about 5 or 6 categories that come from that Beck Depression Inventory. The vast majority of the 80 were moderate to severe depression. And the reason for that is they're living in chronic pain with facial pain and headaches that they can't control, and weak jaws and difficulty chewing and pain, facial pain. And then we treated their TMJ with this process known as Disclusion Time Reduction, which is what you read from Dr. Sutter's post on Dental Town. Disclusion Time Reduction is a specific application of the T-scan that treats the time of excursive contacts down to fractions of seconds. And when you treat the disclusion time, you turn off muscle hyperactivity. It's a direct effect that's been shown through EMG studies, and you can actually go back. My first paper on the disclusion time was in 1991. So we treated these 80 patients with disclusion time reduction, and then within a few weeks, they filled out a new Beck Depression Inventory. So they were treated, and at 3 weeks, they filled out a new Beck Depression Inventory. From the 80 that were clinically depressed, after 3 weeks, about 17 were borderline depressed. The rest were no longer depressed because their chronic pain had left them. At 3 months, only 2 of the 80 were borderline depressed. 78 were not depressed. And again, they filled out a Beck Depression Inventory at 3 months. And so the nature of TMD being emotional is really not true. The truth is that the emotions come out of living in chronic pain and having dysfunction and not being able to chew and being, having headaches that interfere with their daily life. And when you treat that, the chronic depression goes away. And so we have, again, shown in research that this concept that TMD is an emotional problem is not true at all. But it gets perpetuated because people want to keep these beliefs of the past going. Just what you said about these zombie beliefs, they keep them going.
Okay, I'm sorry to just go into a totally different direction, but now there's a lot of TMD theories being added and combined with sleep apnea, and
Yes.
and that's throwing out a lot of new things. There's been guys that come on this show that said if you make a night guard for somebody and you don't screen them for sleep apnea, that it's malpractice. So how does the TMD occlusion play into sleep apnea, snoring, and appliance therapy?
Well, it's fascinating, actually, where, again, the disclusion time and the disclusion time reduction has been shown in clinical reports to open the airway without having to use an appliance because it relaxes all the muscles that are involved with swallowing and breathing that the teeth hyperfunction. So the teeth play a huge role in constricting the airway, and making an appliance does 2 things. It keeps their teeth apart from constricting their airway to some degree, but only when they wear it. When they chew, eat, and swallow without it in, then the muscles get constricted again. And the forward appliances, the sleep appliances that move your mandible forward and keep the airway open, they mechanically open the airway. But again, when you take it out, the teeth come back together and constrict the muscles. So there's huge implications for the teeth in sleep bruxism and in airway. And yet the sleep community has consistently discounted the role that teeth play in sleep. Everyone seems to continually advocate that the teeth are, like not a component of sleep bruxism, that it's a central nervous system problem and that it's psychological. And it's not true. We have studies since the 1990s which show clenching and grinding and nighttime bruxism goes down in patients, and people don't wake up feeling facial pain when they have this disclusion time changed. So there's a very serious direct effect to sleep. It's now being understood. We've been seeing in airway CTs, after the disclusion time is reduced, the airways widen. And this is because the throat muscles, the teeth have a direct effect on the muscles of swallowing. And the unique neuroanatomy of the teeth, the posterior teeth, not to get too technical, but in simple terms, they talk directly to the muscles that control swallowing, and your brain controls swallowing because it's a survival skill. So the teeth, I think you'll find this interesting, Howard, peripheral nerves do not synapse inside the central nervous system. They all synapse outside the central nervous system. They stop outside the spinal column and enter ganglia, and then they travel from the ganglia into the spinal column. Only the proprioceptors from the molar and premolar PDLs and the molar and premolar pulps go directly into the brain, and there is no synapse outside the brain. They're the only peripheral nervous structure that does that in the entire human body. And then when they synapse, their synapse is with the muscles that control swallowing. And so what happens is every time you rub your teeth together, you contract a lot of muscles. And so as people use their teeth to chew, eat, swallow, if they clench and grind, they contract all these muscles automatically that can't be controlled by the human. It goes on automatically. And so over time, this use of the teeth constrict the throat, constrict the muscles of mastication, tighten up the head, and you get symptoms of muscle fatigue in patients that are susceptible. So the airway and the swallow mechanism are directly tied together. And so we're seeing now with airway CTs, as I said, you can see a widening of the airway after disclusion time reduction when the muscles of the swallowing mechanism all relax, which is why the symptoms go away, and it's why the depression goes away. So there's huge implications for treating the teeth involving sleep.
Okay, now I'm going to get you in big trouble. Okay, how does that sound? Now I'm going to.
Hopefully not.
Well, hopefully I will, because here's what's going to happen. She's listening to everything you're saying now, and then she graduates, and she's going to go back to a small town, Texas, with Mama, who's a dentist, and Mama only checks with articulating paper. If someone's grinding their teeth or has TMJ or whatever, she's just going to have the assistant come in, take out parental alginates, and make an occlusal tray, right? A bite splint. And she'll check that a couple times. And that's the extent of TMJ in small town mid-America. So how do you, and then she starts hearing things like deprogramming. And then when she talks to her mom about that, here's what her mom's going to say. And ask me how I know, because I was sitting in a bar in Beeville, Texas, listening to a girl talk about her mom. They were both dentists, and her mom was there. And basically, the bottom line is her mom saying, they don't, what do they know about occlusion? I mean, first it was the joints were up and back, and then it was down and forward, and now it's out to the left and the right. They don't know where the hell it is. This works fine. So how does a little 25-year-old girl, it's her mom. Her mom's 30 years old. How was she supposed to go back to work with her mom and start a different TMD protocol?
Well, that's a very good question. I think it comes from within the practitioner. They have to want to apply what we know now, 30 years later, from what all those concepts you're mentioning have been refuted. And it's the modern era of digital dentistry, where we know things because of MRI and CT and T-scan and imaging and biometrics that are available to any practitioner to learn. And it would take her own personal strength to want to learn those things and maybe make a change in her practice as to how she might approach it. I really, I know it would be hard with a parent saying, no, you don't need to do that, or elder. Let's say if you're an associate in a practice, it would be difficult to do that. But the longer that young person goes without learning really the new understanding, the more likely they are going to struggle with occlusion in their practice and create potentially a number of untoward scenarios.
Yeah, I'm just gonna ask you some questions. These are common questions I ask on dental time. So I'm just gonna ask you. I got the man on. What is a deprogrammer?
A deprogrammer is a device that separates the back teeth and allows the muscles to relax because the back teeth no longer touch. So can be made out of acrylic, it can be made out of resin, it can be made out of it can be prosthodontically made, cast in gold if you really wanted to go crazy. But it's, an NTI is like a deprogrammer. They're just barriers to the back teeth. There's no contact on the back. There's only contact in the front. And the way they work is they disclude the teeth, and that's actually their mechanism of action. By discluding the teeth, they cut down on this synapse that I was talking about, the back teeth creating contractions of the swallow mechanism muscles. And so then the system can calm down. Sometimes it works and sometimes it doesn't. I mean, there are plenty of people that came into my office who had a bag of deprogrammers who were still having symptoms, because when you chew, eat, and swallow, all the muscle activity mechanisms go back into place. And so a deprogrammer can't stop that.
So when you said NTI, and that one is actually that is now an exclusive only at National Dentex Labs, and that's the only publicly traded really dental DSO. I mean, there's no dental DSOs publicly traded in the United States. There's 2 in Australia, 1 in Singapore, but we do have dental laboratories are publicly traded through National Dentex Labs. It's mostly all the owners are in China. It's basically an Asian low-cost labor play. But you're the one that said NTI. Do you have a favorite deprogrammer? And do you use them? Do you use them very often?
I rarely used appliances because of the T-scan. I was able to practice without making night guards, deprogrammers, multiple years. I only used occlusal guards in very isolated situations because the T-scan and shortening the disclusion time controlled all the muscle physiology problems in many, many people. And that's what Dr. Sutter was talking about when he's posting on your forums. So I was able to get away from making appliances in the early 90s and continue to do that. But I will say that they're very helpful. They can get people out of pain, and they don't have to be sophisticated. They just have to keep the back teeth apart. So they work really well to do that, and then symptoms tend to wane.
So you don't use make night guards either?
Very rarely. Only if someone who, well, I have to preface that by saying most of the patients that came to see me already had 1 or more appliances, and they weren't getting resolution. And it wasn't because the occlusion wasn't designed well on the appliance. It's because the neurology of the pulps and the PDLs override the appliance's ability to control the symptoms. So a typical scenario that illustrates that would be someone would come in, let's say they were 50 years old, and I'd ask them their history, and they'd tell me when they were 25, their jaw bothered them, and they got lots of headaches, and they were grinding their teeth, and they got a night guard. And the night guard worked for a while and helped them. But as they got older, into their 30s, that same night guard stopped working. And so they got another one. And that new one didn't work like the old one originally worked. And the reason for that is the neurology has been amped up for another 5 or 7 years because the appliances can't control the neurology. So over time, the normal occlusal function, and I'm not talking about clenching and grinding, I'm talking about chewing, eating, swallowing, overworks the head muscles who in a susceptible patient to where the appliances have no effect anymore. So when someone came to see me because they knew I had an alternative approach, they weren't coming to seek out an appliance. They were coming to get treatment of their occlusion. So I got away from making them because most people who came to see me had them, and they weren't effective anymore. In a typical practice, an appliance can be very helpful to alleviate symptoms and help people get more comfortable, and then their occlusion can be addressed. And another great application of the T-scan is to treat the appliance with T-scan data. And then you have a much more controllable appliance because an appliance, let's say we make one and we just use articulating paper. What if the imbalance on the splint was 75 left, 25 right. That's not going to help the left condyle. That's not going to help the left joint space. It's not going to help the left musculature. But you wouldn't know that without a T-scan, because the T-scan shows you what the imbalances are. So you can take the T-scan and use it on a splint. It's one of the great uses of the T-scan. So, but in my own experience, I was not called upon to use appliances. I was being called upon by the patients to help them directly with their occlusal problems.
Okay. So you talk about TechScan, and there's another country called Germany, and Germany has a company called by Dr. Jean Bosch. Bosch are articulating, and she's come up with the what is it? The Occlusants by Bosch.
Yes.
Occlusants. Have you heard of that?
Yes, of course.
And I know, but I got to ask. But anyway, so what are your thoughts on it?
Well, I think it's really great that there's another digital tool entering the marketplace, because digital occlusion is the forefront of occlusion. It's the future. But it's important that the listeners understand that digital occlusion means working with data. And you have to ask yourself, what does the data tell you? Well, at the present time, unlike the T-scan, because we've been working with it for 30 plus years, OccluSense data is not understood. It's not a T-scan. So if someone tries to use it, they're going to have to interpret what it's saying in ways that are not known. And this is a very important thing to grasp. Digital occlusion is using data and metrics, and the OccluSense metrics are not understood as of yet. And I can speak to that because when T-Scan 1 came out in 1984, we didn't understand the metrics then either. And through testing and through research and through testing the sensor for accuracy and understanding what the data meant, we were then able to apply that data to make a better denture, to make a better crown and bridge insertion, to treat TMD more effectively than with appliances. And so OccluSense data is not understood. And I think this is very important to understand. And it's interesting, Jean Bosch was asked about the T-scan, about Dr. Sutter actually wrote a paper comparing the two, and he found that there were a lot of improvements in the T-scan that the Bosch product doesn't have. And when Jean Bosch was asked about that comparison paper, in her words, or I'm not sure if it's a he or a she said, well, it's really not a T-scan. So I think it has a long way to go before it has clinical application. It's just not understood. And as I said, digital occlusion is using data. And until the data is known, a clinician is not going to be able to apply it in a clinical sense with any knowledge of what to do with that data.
Interesting. I knew you would know. That is kudos for knowing everything. I just know when I get off with you. So are we okay to do overtime?
Yes, whatever works for you.
Okay, because I know I know each punch I'm going to get in the stomach if I don't ask you, and I haven't even asked you about pharmacology yet. There's in the last 30 years, a lot of dentists, someone starts grinding and they get an episode, they would give them what was the most common one? It wasn't Valium. It was Ativan, wasn't it? Like 10 nights.
Valium was used. Valium was used a lot. Right. Diazepam is Valium in generic form.
Yeah. So is one of the tools in your toolbox pharmacology at Walgreens and CVS?
For a toothache, maybe, but not for muscle relaxation. Again, the muscle relaxation can't come externally. That's why Botox fails every few months. That's why medications have to be continuously taken. The only way to relax the system is to treat the occlusion in specific ways, which we've been studying for a long time. And actually, there are a number of studies in the literature that I've published that show we can reduce medication ingestion by treating the disclusion time. Again, the same entity we've been talking about has a very far reaches in terms of how it affects the head. And so I would use medication sparingly as part of my treatment. It would not be a frontline treatment. It would usually be after treatment. If someone was struggling to get good healing, I would assist that healing with medication, but not as a primary treatment. And so it's interesting, the Beck Depression Inventory study and another study from the past, the 1997 study that we did showed clearly that people could reduce their medication ingestion once their disclusion time was treated properly. So there's, again, a huge advantage to the human physiology, a great benefit to the patient if they can take less medication.
Now, you're in Boston. So
Yes.
if they're Irish, you just give them Jameson, or is that do you treat the Irish completely different?
I tried to give everyone the same high quality care. You know,
Really, even if they're
yes.
Irish, that is amazing. So pharmacology is not a big deal. Another one is if I asked any dentist the first 10 years out of school, what's the scariest monster in occlusion? I know what they're going to say. They're going to say opening the bite. And all they want to do is never do that, because they know if they do, the clouds will open and a tornado will suck them into the universe. Why is that one of the scariest concepts, and what do you think about that?
Well, it's interesting. Mark Piper has shown that you can open the bite a long way and help patients, with certain structural problems in their jaw joint. So it's scary, I think, because you have to re-occlude the teeth at a new place. And that means creating a new jaw position and either orthodontically bringing them together or prosthodontically bringing them together. And of course, that forces the practitioner to treat one arch in total, one way or another. Something has to be done to re-occlude the teeth. So it's a big undertaking. And yet, from the standpoint of succeeding, we actually have a fair amount of room to open the vertical within reason. So, and it's something that we do routinely in prosthodontics when people have worn their teeth down, when they're sanding them into dentin, or if we feel their vertical face height is too closed. So in dentures, we have a lot of latitude with vertical dimension. So it probably shouldn't be as scary as it is. But from a young dentist standpoint, who hasn't done any kind of full mouth prosthodontics, it would be the complication would be, now I have to put all the teeth back together at this new vertical. How am I going to do that?
Okay. Now I want to switch gears again on you. You're probably gonna think you're dizzy when I'm done. So the two fastest growing segments of the global dental economy are obviously implants and clear aligners. And so whenever you go to ortho, let's start there. Whenever you go to ortho, it seems like the really hardcore occlusion guys, they're not impressed with how orthodontists treat occlusion. They're like, man, they blow out the curve of speed, they blow the Wilson, they do 4 bicuspid extraction. They don't have a lot of respect for occlusion. And then a lot of them sit on the sidelines and say to these young dentists coming out of school, dude, if you're going to go into clear aligners, like if a patient has a small mandible and an anterior deep bite, that's just going to be a TMD case waiting to explode. So I know I threw 20 ortho questions at you because they're all so dumb. I'm hoping one of them might be good enough for you to bite on. Did you see any of those questions as bait that you could respond to?
Well, I can tell you from either being a co-author or from editing orthodontic papers that involve the T-scan, which there are many actually, clearly the orthodontic treatment tooth movement isn't precise, even though it might line the teeth up nicely. It doesn't provide for high quality occlusal endpoints. But they're not gross endpoints like the curve of spee isn't good, or this inclination of this tooth isn't good. There's that in there as well, but I'm speaking about the micro occlusion, how the teeth relate to each other and what that means in terms of the head and neck neurology. Orthodontic treatment tends to hyper-occlude the posterior teeth and either non-occlude or very lightly occlude the anterior teeth, and that creates very difficult scenarios for people. It sets them up for excessive muscle activity being made by their head. So that's a very significant concern in terms of how orthodontic treatment end results are. But another one of the great applications of the T-scan is that you can case finish the orthodontic patient to very high tolerances and stop them from having future occlusal problems if you finish their braces or their aligners using the T-scan. It's a great way to optimize the end results.
So, are you familiar with Donald Warren?
No.
Okay, Donald Warren. That was another occlusion deal. I'm trying to think. I just want to make sure I'm not missing anything that one of my homies is going to get me for. Gosh, I think we've done so much. So now I want to leave the country. I've jumped all around. Now let's go leave the country. When I go to major, like Poland, I mean, Poland, what a huge country. Chirodontics has taken off, and they took off with a lot of the occlusal people. The TMD people, and now when you go to a major dental meeting, and I probably lecture in Warsaw every 5 years, there's actually chirodontics. Marcin Dalecki. Do you know Marcin Dalecki?
No.
Probably the most famous chirodontist in dentistry. But it started within dentistry. And then as he's getting older, went from single tooth to quadrant to full arch, and started learning into TMG and TMJ, and then that followed the whole body posture and the whole thing. Yeah. But have you heard of chirodontics, and what do you think of it?
Yeah, of course. I think it's a great combination of assistive therapy and dental components that. Certainly, people can benefit from having the therapy applied. But again, that alludes to the idea that the occlusion is not at the core of what's really going on. And this is what's being lost on many dentists throughout the world, is the neurology is not being considered. And the neurology of the teeth overpowers all of these therapies. So a person who gets assistive chiropractic care can't get better until their occlusion is no longer throwing off high muscle activity and tensing up their whole head. And so there's repeated therapy. It's like Botox. You just keep having to go back. Whereas when we treat the occlusion with the T-scan definitively, we don't need Botox very often. So there's a lot of things that have not made it through to the mainstream. And some of that has to do with that the measured occlusion studies haven't necessarily made it through to the mainstream. But I think chirodontics is an interesting field, and it has applications, but it won't be a curative field without occlusion being a component of that.
Interesting. Interesting. And by the way, you keep talking about Botox and all that stuff, and I just want to say, for the record, if you're watching on YouTube, this is all natural. Everyone accuses me of having a lot of work done. I'm not wearing a wig. I'm going to throw another wild, crazy thing at you. Sphenopalatine ganglion blocks and neuromodulation for managing TMD and or facial pain. Are you a big fan of that or not really?
I'm sure it has applications, but as a frontline therapy, no, I wouldn't call it a primary approach. Again, all of these approaches are trying to neurologically manage the patient or physically manage the patient, but the occlusion hasn't been neurologically managed. So if you give someone a ganglion block, it'll help them, I imagine, for sure, for some period of time until the anesthetic wears off. And then their occlusal neurology will overpower that. And so it's just the nature of the problem. The occlusion is at the core of all of these things. And so external approaches, even one that's internal, like a sphenopalatine block, is still an external approach. It's outside of the occlusion, and its impact will only last as long as the anesthetic lasts. It won't last forever. And when you treat the occlusion definitively, it really does last for a very, very long time, unless the patient has, because we have studies on this, unless the patient has dentistry done. They have a new set of crowns made to change their bite, or they have a filling change that throws their bite off, or they lose a tooth, which changes their occlusion, and then symptoms can resurge. But if the patient's teeth stay pretty stable once they're treated definitively with the T-scan in this specific way that Dr. Sutter was referring to, the disclusion time reduction, it lasts a very long time. And again, we have studies on these things. So it's just the information is not necessarily reaching the mainstream, which is why it's so great that you're talking to me, that because you have such reach. It's really impressive that you have so many followers.
Well, I mean, I'm selling something for free, and it's only guys getting like you on. So, if I was charging $1 for this show, I would be impressed. But it's free, and so I'm telling my listeners, you get what you pay for, right? But I want to ask another. I'm just trying to. I always try to listen to the kids and what they fear and what they're afraid of. Another one is they're always afraid that one day they're going to tell the patient to open real wide and their jaw is going to lock open, and they don't want that to ever happen. They don't ever want to see a patient with their jaw locked out. So first of all, what is a jaw locked open? Have you ever seen one? What do you think causes it?
I've seen it a few times. It's where the disc is malpositioned enough that the condyle can't get past it back into the socket. So it's hard to say exactly what that means, but it's where the disc is out of place enough that the condyle can't move in and out of the socket correctly. So now it's basically in front of the disc instead of the disc being in front of the condyle or over the condyle. Now, when that happens, there's no real treatment for it except to manually put it back. Kind of like you've seen in the movies where someone's dislocated shoulder gets shoved back into their socket.
And how do you manually put it back? How would you describe them to manually put it back?
Well, I tell them to call a surgeon rather than to try if they haven't done it, because many oral surgeons have done it. But it's a downward pressure to try to get the condyle below the blockage of the disc and get up on the other side of it. Sort of pull it down and it'll spring load back up into place because of the musculature and the ligaments and all the things that have elasticity. But it's a mechanical process. It's a manual.
Okay, so hold that thought. Here's my bait and switch. For 30 years, a lot of orthodontists, if you send someone for a TMD consult to an orthodontist, they say, look, this is what they say. They say, look, Howard, if I straighten out my arm, it's my hand's determined by my elbow. If I straighten out my leg, my foot's going to be in a place determined by my knee. And this is the only joint where the teeth are going to determine where my joint is. So what I like to do for my TMD patients is I like to put their joint back, put them in full ortho, and arrange the teeth so their joint can be fully seated with the ortho on. So when I'm doing a TMD, I like to do the ortho first to line up the joints to the teeth, and then we'll take it from there. Now, that's a sales pitch I have heard orthodontists and general dentists say for 3 decades. What do you think of that sales pitch?
Well, on some level, it makes sense that you should align all these things together so that they function together. But the condylar position in the joint space is best served by being under the disc. So that would be the ideal place, not necessarily up and back or posteriorized or too far anteriorly, way down the eminence. Where normally, actually, Mark Piper showed that when you have a slightly torn disc, the best place to make the teeth, the best place to put the condyle is in MIP, where the teeth support the disc when it's slightly out of place. So
you got to tell them what MIP is. They're young.
MIP, where all the teeth meet, they fit together.
Maximum intercostal.
Maximum intercustation, yes. All right. And when the disc is torn slightly, dislocated, the condyle sits under the middle of the disc more often in MIP than in any other jaw position. So striving to have that position be where the teeth meet is ideal. And I think that's what the orthodontic sales pitch that you're talking about is trying to do. So that makes sense. But if it comes out that way, it can only be determined by imaging the joint and seeing where the disc is. I mean, it's just not, it's words. It's kind of like, Howard, people have been saying for years and years and years, and you've heard this, and all dentists have heard this, all the teeth should meet at the same time, right? It's words, right? When you put the T-scan in there, you find out that that's not the case. One side hits too early, 3 teeth hit too early, one side of the arch doesn't come in until very late in the game because of the way the teeth line up. So words don't translate into true anatomical reality. So the orthodontist saying we want to line up the discs, the joints, the teeth, and make that all work is obviously that's the theory. Does the treatment do that is really the true test of that theory.
There's clusters now. There's autoimmune clusters. One autoimmune cluster, people had celiac sprue, they had MS, they had arthritis, they had hypothyroid. Now they're realizing with DNA testing and 23andMe that these are all in family trees. That if you had a family reunion and someone's got hypothyroid and takes thyroid medication, someone else has got rheumatism, someone else has celiac sprue, someone in that tree is going to get MS. Do you think that's a component to TMD? A lot of people are asking, is rheumatism linked to TMD? Do you think some of this is an autoimmune disorder?
Interesting question. Well, I can't speak to those specific conditions being related. I think that's possible because those conditions would predispose a person to be susceptible to their own human functionality. TMJ, as we understand it now through biometric assessments and treatment over the years and doing studies, many, many studies, is a lack of resistance to the overworking of the swallow mechanism caused by the teeth. And so, yes, the person is susceptible to their own body. So in theory, it could be autoimmune in principle. In other words, you might have an occlusion that has all the elements that are poor in it, and yet you don't get symptoms. And someone else has the same elements in their occlusion, and they get symptoms. And we don't know why that is. We don't know what is the reason that symptoms appear in one person, they don't appear in another. So an autoimmune component could very well be at the core of it, but not necessarily one of those disease states. I think a lack of resistance to the muscle activity that is made in the swallow mechanism is a lack of tolerance to, I should say, let me rephrase that. A lack of tolerance to the muscle activity that's made in the swallow mechanism is why TMJ shows up. But what it is that results in a lack of tolerance is not understood at all. And yet it's very prevalent because only certain demographics really suffer with TMJ problems. You know, Asian women are very susceptible. Caucasian women are very susceptible. Caucasian men are 8 times less likely to suffer than women in general, but
That's
they still
awesome.
suffer.
It's now my favorite disease. Caucasian men are 8 times less likely to have this disease?
Yes, yes.
Oh my God, that's the next one
Right.
better than male pattern baldness then. So is it
Well,
and then here's a big can of worms for you. When you see these extreme wear and erosion cases, I mean, they just like a tech scan. I mean, how would you even measure that by? I mean, you've seen them; they wear them all down to nubs, and then you look at these cases and you say, "My God, I'd have to crown 14 upper teeth, 14 lower teeth. I'd have to open your bite." What do you think of when is the dog wagging the tail? Is the dentist the tail or the dog? What does she do when she's 25 years old? She just got out of school. Here comes Frank. He's got a promotion, and he wants to look better. His teeth are all worn down. You've seen the severely worn down deal. He has no pain, no TMJ. He just wants a movie star smile. And at first she's thinking, I got $400,000 student loans. I'd like to prep 14 upper teeth for $1,000 each, seat them, then prep 14 lower teeth. What would you tell her about that case?
I would tell her to refer to a prosthodontist if she's a young practitioner, or take a course in full mouth rehabilitation where she might even be able to bring that patient with her and do it under guidance. There's some very nice hands-on continuums that actually have you bring patients and treat them, and then you learn.
Any of them by name? Any of them you recommend by name?
Well, Aesthetic Professionals in California is really run by Bruce Crispin and his daughter, Christy Crispin. They teach a variety of on-patient courses that teach people how to rebuild mouths and deal with aesthetic reconstruction, but it's all, with the patient. And of course, LVI is also hands-on with the patient continuum, and they often do full mouth rehabilitation. So, she has places she can go to learn, but in the simple early evolution of a dentist, it would be best if she made an appliance and referred that person to someone who can address a full mouth case like that, and then learn how to handle those things. I mean, it looks appetite whetting when you see 28 units to be made, but as a prosthodontist, I can tell you it's a big undertaking, and there might be many endos, there might be gum surgery involved, there might be minor ortho, depending on the positions of the teeth. Those treatments, they can take up to 2 years. So, it's not like doing 28 single units where they're over in 2 visits or 3 visits. It's a very, very different process. And I would caution a young dentist to jump into that because they see they might be excited or they really want to help the person, but their best strategy would be to make an appliance that would curb some of the damage and refer them to someone who knows how to manage it.
That was a really good answer. And Bruce Crispin is a He really is an amazing guy, isn't he?
Yeah.
He was on the show. He was number 1245, and the reason he was on first over than you is because I asked you in the first 10. I've been asking you for 4 years, so I'm still just excited that I got you on the show. So
Well, I'm honored.
so I want to say one thing to the kids though is that the fastest, five fingers. What's faster? What's easier? What's higher quality? What's lower cost? What's smaller? And you don't want to hear the answer. The answer is a book. And I have no connection with Robert and his books, but I mean, he's got the Handbook of Research on Clinical Applications of Computerized Occlusal Analysis in Dental Medicine. It's 2 volumes, and my gosh, when I want to update some, I'll read the new Pathways to the Pulp. Well, Pathways to the Pulp by Stephen Cohen and all those chapters. I mean, my God, that's got to be equivalent to taking 21-day lectures. And I remember when I went to the missions, dude, I just was blown away. It's like people would be asking questions like, dude, he answered that in chapter 1. I mean, it was like 7 3-day weekends, and on the 7 3-day weekends, people were still asking questions that were covered in the first 3 chapters of his book. And I'm telling you, kids, that you could get this guy's book, and I mean, you might have to read it 3 times, but I know it sounds fun to go get in an airplane and fly to Phoenix or Seattle or LA or something sexy because you live in, Toledo, Ohio, and it's snowing outside. But damn, just go to a resort there with your family and read the book. You don't have to go to that resort and then leave your kids and your spouse in the hotel room because you're sitting in a lecture. I mean, Abraham Lincoln was probably one of the greatest lawyers in America, and he never even went to law school. He went and sat in the library for 6 months and passed the bar exam, which you can still do today in several states. You don't need to go to law school. It's in the Constitution. I mean, it's different. So I would rather you go to a resort with your wife and kids and just read. How long do you think it would take if he just sat down and started reading your 2-volume book? How long do you think it would take to read it one setting? If you just read it like you would a sci-fi.
Well, first, it's the new one is 3 volumes, so it would take a little longer than the 2-volume. Interesting question, because understanding the T-scan, it requires certainly study, but it requires also hands-on exposure. It's not, I don't know if if you can relate to this, but I remember being a dental student, and we were sent to gross anatomy to cut up the bodies, learn the head and neck. And the night before, I would read the section. So if it was the ear or the mouth or the whatever we were cutting up, I would read it, and there were all these words and all these structures and all these nerves that traveled through all these holes, and it was pictures. Right? It was looking at the pictures. Even the really great, there was one atlas, I forget the name, that was actually dissected pictures, and it was amazing to look at. But it didn't stay with me. I didn't go there the next day and say, I know that's the foramen valley, or I know that's the this, or I know that's the that, because I didn't have that frame of reference. All I had was what I read in words and a picture of it. It wasn't until I actually did the dissection and I peeled back the fascia and I saw where the muscle attached to the bone and I saw where the nerve came out of this part of the skull and went to this structure, did it stay with me? Well, the T-scan is like that. You can read a lot about it, but you need to have a hands-on reference for it. You need to understand what the data means in somebody's mouth, even if it's just cursorily recording on patients and learning how to record, not doing any treatment, just to get a feel for what the data is showing you, and then have explanations of what the data is showing you. So I would say if a person had training on the T-scan, at least initial training, they would have a much more success reading through the book. Without that, it's just a lot of scientific occlusal information that, although very valuable and very valid and certainly scientifically tested, is not yet understood by the average person without a hands-on frame of reference. So they'd have to do both together, read and have hands-on training.
Now, this Dentistry Uncensored, so I'm going to have to level with you and be honest. The final thing I have to say to you, you do know that as a D.M.D, you're not a real doctor. I'm a DDS. I'm a real doctor. You are not. because you're a DMD. And if
Yeah.
I'm not even kidding with you, because if you go to Outlook and you put Robert Kerstein DMD, it populates your name as your last name DMD. It only recognizes the DDS degree, which was the first degree, University of Baltimore in 1850. And that's what Amazon did to you. When you go to Amazon and you search your name, you have to put in your last name is DMD, because it has you as DMD Robert B. Kerstein, and it's just going to kill your SEO on that site. So you need to go to Amazon and fix that DMD. And I do wish, and I'm being serious, it's not fair for the patients. There's 325 million Americans, and they see MDs and DOs. They see DDSs and DMDs. And in Phoenix, Arizona, where it's all a transient society and nobody's really born here unless you're a millennial or younger, we always get questions, what's a DDS or a DMD? And what the American Dental Association needs to do is just make it one. I don't even care what it is. It just the only way you could have one guy be a DMD and one guy be a DDS is if there was a difference in training and you could measure. You're talking about biometrics, measuring something in biology. Well, where's the dental education metrics that separated DDS from a DMD? And here we are on Microsoft and Amazon, doesn't even recognize a DMD. And I'm telling kids to go find your book on Amazon, and if they go search your name, well, they don't think your last name's DMD. So please fix that on Amazon, and I'll give you a marketing deal. It would be so unbelievable if you did millennials like online CE, and they like it in short units an hour. If you did an hour online CE course on Dental Town that just summarized your 3 books, if they fell in love with you and you got them interested in it, and in that 1 hour you piqued their curiosity, and that's what a leader has to do, you'll lead them to go read all 3 of those books. And I bet to read those 3 books would be a summer. Don't you think it'd take a summer?
Take a while.
Oh, I mean, what do you think it'd take a 25-year-old to read that, paying attention, not on their Facebook, put their Snapchat away, and just read it and learn it? How long do you think that would take them to read it if they're working full-time?
Easily a number of months.
Yeah. So that's my advice. You got to change. You got to change your Amazon account. DMD is not your last name. It's your degree. And then I'm Howard at dentaltown.com. The other Howard is Hogo, Howard Goldstein, so he's Hogo. Yeah. He lives in Bethlehem, Pennsylvania. I wish you do an hour course to summarize these 3 books. And because, like I say, you said at the beginning, we started the show that they're well trained on cavities and gum disease.
Yes.
But occlusion is the weakest of the 3 right now. That's where we're at right now. And it's all going to change rapidly because, like I say, with digital everything. I mean, I lived through, when I got out of school in the 80s, it was the materials revolution. We were going from full gold crowns and PFMs and amalgam to these composites and all this stuff, So the first decade of my life was this huge dental materials revolution. And then that was, as soon as that started to get stabilized, where you kind of figured out which bonding agent, are you on 3rd generation, 5th generation? I think I'm on Pi generation bonding agent. Then the digital revolution came out. And now it's 2020, and I think the Invisalign, hell, they're on Squawk Box talking about how all these scans are going to start getting some measurements on TMJ. But anyway, it's going to be a fun, exciting thing to watch. It was an honor and a privilege for you to come on the show and talk to us today. Again, I think you're the most quoted TMJ guy on Dental Town. Thank you for that, and thank you for all that you've done for dentistry and continue to do so.
Well, I'm honored to be here, and thank you for asking me to participate with you. I hope it was helpful to your listeners.
And my only question is my goal was to try to make this podcast. I know you're from Boston. I was trying to make it longer than The Irishman, but I realized I'd have to go 3 hours and 30 minutes. So I apologize to all the Irish in Boston that this podcast was not as long as the movie. But
that's okay.
All right. Have a rockin' hot day. Thanks for coming on the show.
Yes, my pleasure.